back. I hope you've had time to recuperate, have a breather. Right now, we're going to continue this amazing discussion on equity, ensuring equity in the mental health services with Margo Wrigley, ADHD in adults, the evolving response in Ireland. So Margo Wrigley is the consultant psychiatrist now working at the HSE Mental Health Clinic programs at Dr. Stephen's Hospital. Currently National Clinic Lead for Specialist in Perinatal Mental Health Program and for the Adult ADHD National Clinic Program. She previously worked at the HSE National Clinic Lead for Mental Health. Prior to that, she was Executive Clinical Director, Dublin Northwest and Central Mental Health Services. Her main interest is in service design and implementation. So she has designed national service model in psychiatric of old age, having just set up the first service in Ireland. She also designed mental health intellectual disability service for Dublin Northwest, now implemented, and the mental health service for people who are deaf. So this will be a 30-minute presentation with 15 minutes Q&A at the end. And you can put your questions in the box. Hello, Margo.
Hello, nice to meet you. And I think you're going to very kindly move on my slides for me. Or
yeah, I'm going to do that, Margo. Can you see the slides on the screen?
Yes, I can.
Yes.
Thanks very much. Yeah. So first of all, just to thank you very much for the invitation to talk at this conference. I'm very honoured to have been invited. And what I'm going to do is talk about the evolving response to ADHD in adults in Ireland. And it's really in three parts. First of all, how I got involved. And I think I was probably one of the first psychiatrists who, in adult psychiatrists, I should say, because obviously child psychiatrists and learning disability psychiatrists are very involved for years, but in adult psychiatry, who became aware of and felt a need to develop the services. Then I'm going to talk about the model of care and then about the issues that are facing us now. So the next slide, please. So I first became aware really of ADHD being a potential problem in adults when I was working as the manager of the Dublin North Mental Health Services, which covered all specialties. And this was really on foot of a complaint from a middle-aged man who'd been seeking treatment for his ADHD. He'd originally come from the US and he had his GP refer him to the local mental health service, and the referral was declined, and then it's made its way up to me to try and deal with it. And my initial thought was, well, I better just write back and say we don't have such services. But then I was caught up really with my own situation as the mother of a young teenager with ADHD. And it was really bizarrely enough the first time it ever occurred to me that perhaps when she was 18, her ADHD wouldn't go and she would need some ongoing assistance with it. So I discussed it with my consultant colleagues, and one of the newly appointed consultants in adult psychiatry actually did know about ADHD in adults. He'd done the training that's organised through UCAN, which is the UK Adult ADHD Network. And so I worked with him on looking on how we might consider designing a local service response. And we were really looking at doing something very minor at that stage, which was maybe he would have a couple of sessions or a day a week, and also we would get some OT time. But for those of us who listening in who are from Ireland will know that we were actually hit by the most appalling financial crisis in Ireland round about that time, that continued for a few years, which meant that we could not get any funding to develop anything. And in fact, the services were asked to close what they were doing in some areas. We had to close 5 high support hostels, for instance, in our area. So despite many attempts, we couldn't get any further. Next slide, please. So around about 2014, I moved on to a new post, which was National Clinical Advisor in the newly established Mental Health Division in the HSE. And I was told that one of my important roles was to identify service deficits. So I thought it might be my opportunity to once again flag the need to provide for adults with ADHD. And that was considered over a period of time. And then the division did agree to prioritise adult ADHD as a service deficit. And I was asked to set up a national clinical programme, which is how we develop new services in Ireland, not just in mental health, but in surgery, medicine, etc., within the HSE. Next slide, please. And around about that time, I actually retired in mid-2017, and I was asked to continue working as the clinical lead for that programme, and asked specifically to establish a working group with an agreed terms of reference and to make sure that we had service user input. And I contacted Ken Kilbride of ADHD in Ireland and was very, very grateful to have nominated someone with ADHD to the working group who made a substantial difference to all our considerations. So over a period of time, we designed the model of care that was approved within the mental health division. And then it was also considered by a clinical advisory group set up by our parent college. And that was chaired by Alan Murta, who is a consultant with expertise in adult ADHD. And he agreed, and his group agreed, it was in line with the NICE guidelines, best evidence-based clinical practice. There was, I have to say, some reluctance on the part of the college to consider responding to a condition that's known as a neurodevelopmental condition in medical terms, but nevertheless, that was the response. So next slide, please. So I'll now move on. So that's a bit of background. So as you can see, it took a few years even to get that far. So I'll now talk about the model of care that was designed by the working group. And it specifically targets adults who have 2 of the 3 core symptoms of ADHD: inattention, hyperactivity, and impulsivity, together with functional impairment in 2 or more areas of their everyday life. So things like socialization, relationships, work, education, and so on. So these are the DSM-5 criteria for diagnosis. The next stage of the model of care was to consider what it should do, and it was to provide for expert specialist assessment of people presenting with possible ADHD. And this was by means of a comprehensive mental health assessment, history and assessment, to also include using the DIVA, which is the diagnostic interview for adults with ADHD, to get an informant history with the consent of the person, usually a family member, partner, or whoever they would like us to contact. And then we considered what treatment should be recommended, and we recommended multimodal treatment, which essentially consists of ADHD-specific medication, psychoeducation, OT interventions, and psychology interventions, the latter 2 ideally in group format, because there is no doubt, and the feedback from people is that if they're in with other people who have similar problems, they can learn an awful lot from each other and help each other as well. And all of the above is in line with the NICE guidelines. We recommended the team to deliver this program would consist of, or each of the services in the particular geographic areas would consist of a consultant in general adult psychiatry, senior OT, senior psychologist, a clinical nurse specialist in mental health, and a grade 4 administrator to support the work of the team. Next slide, please. So we then spent a long time researching what service models should be developed. And a lot of this were parallel lines that we were doing at the same time of investigation for the model of care. And as you can see, we summarized them as these being the main service model, but certainly internationally, there was no one service model that was deemed to be the way to go and everyone should follow. We found that there were problems occurring with not being able to provide all the interventions, for instance, the quality of assessment, not being able to provide the pharmacological interventions for those who need it, etc. So in the end, we came down to a combined secondary and tertiary care model. So to put in place our recommended team overlaying the adult mental health services in a defined geographic area. Next slide shows you the referral pathway. So essentially for adults, which is on this side, as it were, adults who think they have ADHD would in the first instance talk to their general practitioners, who would carry out a brief assessment, and if they thought it appropriate, would refer them to their local mental health team. That team would both ask the people to carry out screening, some screening for ADHD. And because, as we know, there's high rates of comorbidity between ADHD and other mental health problems like anxiety, depression, even bipolar disorder, that if there were significant mental health problems present, they would be treated first. If they were not, they would be referred on to the ADHD team, who would carry out the assessment I've outlined and offer tailored treatments depending on what the person themselves felt would be most helpful to them. For young people who are attending the child and adolescent services who had a diagnosis of ADHD, we had a transitional pathway that meant that they only got referred to one of the two services depending on their needs identified at the time. And that required that there would be a formal reassessment at the age of 17 of the young person. And then they would be directed towards adult mental health teams or ADHD teams, depending on which team would be more appropriate for their needs. So that's the clinical pathway. And the next slide, please, shows you the distribution of the proposed ADHD clinics in the country. So you can see the various counties of the 26 counties in Ireland, population, so with one team per 300 to 400,000 working age population, and then the distribution of the teams. So there'd be 11 teams nationally. Next slide. And we also recommended that there would be one further team that would work in association with the forensic mental health services in Dublin, because that's where the bulk of people, the prisons are in Dublin, and we know there's high rates of ADHD amongst people who are imprisoned. So the implementation really was the next stage. And this started really with the formal launch of the model of care by Minister Butler in January in 2021. And at the time, we were allocated 1.3 million to set up 3 pilot sites for specific areas around the country. And for the rest of 2021 into 2022, we worked on recruiting all the staff for those 3 sites, identifying accommodation for the 3 services. And any of you working in the HSE will know that that's easier said than done. So that can be quite a struggle at times. And then organising training of all the newly recruited staff. And that was provided for us by UCAN, who provide a very high level of training in terms of assessment, diagnosis, pharmacological interventions and psychosocial interventions over a 3-day period. So next slide, please. So the progress between last year and this year is that the 3 pilot sites were all established last year. So one for Sligo, Leitrim, Donegal, one for Dublin South East, North and South Wicklow, and the 3rd one for Limerick, Clare and North Tipperary. We had also built into the model of care that activity data would be collected monthly from each service. Unfortunately, we don't have an individual patient identifier, so we can't look at, for instance, we can just look at raw figures of activity, number of referrals, number seen, and so on, rather than looking at individual outcome data and also getting individual feedback from people. When the 3rd service was established in July of last year, I established a National Oversight and Implementation Group, and this group meets monthly. All the psychiatrists are on it. We have a representation from each of the disciplines on it as well. And that's really to support the implementation of the programme, so it allows for early identification of problems and dealing with them. And as part of my role as clinical lead, I also do site visits. So I've done 4 of the 5 services we've set up already this year, so just one left to do. We also built in an evaluation of the 3 initial pilot sites by the UCD School of Psychology, and that's underway now. And last year, then, we were very fortunate and we were allocated additional funding of 1.8 million by Minister Butler to establish 4 more sites, 1 rather smaller site, 3 bigger sites. And for the rest of 2022 into 23, we recruited and continue to recruit for these 4 new services. And we provide training for them again through UCAN as the staff come on site. And this year to date, 2 of the new sites are now operational, and a 3rd site will be starting this summer. Next slide, please. So that's the model of care, and if there are any queries on it later on, I'd be happy to answer them. So I think one of the strengths of what we've been doing is that I have had the great good fortune to be able to work in partnership with ADHD Ireland, Ken Kilbride and his colleagues, and the UCD School of Psychology Professor Jessica Bramham, and also 2 postdoctoral students there, Christine Boyd and Christina Seary. And we have undertaken a number of projects that I think have added really to what we've been able to, I hope anyway, to provide for adults with ADHD in Ireland. So to highlight the issue, we were fortunate in that we got a grant from the National Office for Suicide Prevention to look at suicidality and repeated self-harm in people with ADHD in Ireland. And that was useful in showing how this is a really big problem for people, and again underlines the need to provide services for those who are impacted upon by their ADHD symptoms. We've also completed the first part of an investigation into 3rd level clinical and disability support services for adults with ADHD. So we have the first part was looking at what services are available in the 23 3rd level institutes in Ireland. We've completed that bit, and the second bit has been looking at feedback from students with ADHD who've agreed to answer a particular questionnaire that was developed. And there are over 600 students have replied to that, and that data has been analysed. So it'll form, we hope, a useful report in advocating for 3rd level students with ADHD. We got a grant from the National Women's Task Force in December last year, and we're now starting on a piece of work looking at ADHD in women in Ireland. And Ken of ADHD in Ireland was very keen we'd look at socio-economic impact of untreated ADHD in Ireland. So that study is now starting too. Other outputs are that we've developed an app for adults with ADHD, and that was launched in November 2022 by Minister Butler again. Ken keeps an eye on the number of downloads, and earlier on in May there were 10,000 downloads of that app, and we're also carrying out an evaluation of that just to see does it need to be modified in any way to meet the needs of the people who are accessing it. And finally, we've developed this program called UMAP, Understanding and Managing Adult ADHD program, and this is a program that is delivered as workshop, 6 sessions in each workshop, and it's delivered through ADHD in Ireland. It was piloted last year, and we were fortunate. We got a grant of 50,000 from the HSE that allowed us to roll it out on a number of occasions, taking on board the outcome from the pilots, and in particular that one of the 2 facilitators would have ADHD. And I'd like to thank in particular my good colleague Aisling Leonard-Curtin, who's involved in rolling out this. We also got funding from the HSE this year to roll out 20 cycles of this workshop. Feedback is very good at the moment, but we're also carrying out a formal evaluation of that program as well to make sure that it is really meeting the needs of people with ADHD. It's based on psychoeducation and acceptance and compassion therapy. Next slide, please. Next slide, please. So the sort of factors that are for consideration now are that as the pandemic has exposed a huge need for people specifically with ADHD, because the system of working at home or studying at home has had a profound impact on people with ADHD, because there's a loss of structure, which is always very helpful to them. huge social isolation, and interestingly enough, in some it's manifesting as eating disorders, specifically bulimia and binge eating disorder, but also some with anorexia as well. So that's a result of the pandemic. There's been an explosion in public awareness of ADHD in adults. And I think that's post-pandemic, and because it was so exposed by the pandemic. And we know from our own program's website that we get lots of queries from people looking for assessment. Here in Ireland, we had a particular problem with one of our child and adolescent mental health services in South Kerry, where they were unable to appoint a consultant for 4 years. And the result was that they were depending upon a non-consultant doctor to assess and treat children in that service. And in particular for children and young people with ADHD, the assessment was far below the expected standard. People were not being properly assessed for ADHD, and the treatment that was being offered to them was in some ways very inappropriate indeed. So that has again raised public knowledge about ADHD in Ireland. Internationally, we know that women are often missed as girls, particularly if they present as the inattentive type. And at particular points where women start working or going to education, that's when the problems can become manifest. We're aware that we're getting high referral numbers in our 3 pilot sites, and having to deal with that is one of our challenges. I would just mention what I call the SWAN group of people who seem, with ADHD, who seem to be managing well on the surface, but underneath are, to use the SWAN analogy, paddling greatly and suffering a lot because they find it so hard really to keep tabs on things and have all sorts of external and internal supports in place in terms of routines, admin support and so on to help them survive. And they seem to be doing well, but they're not, and they suffer a lot with these sort of busy brains that are feeling very anxious, very blame themselves for how they feel, criticize themselves a lot, and are generally really very have a lot of difficulty with managing their ADHD, but don't on the surface appear to be doing too badly. Last but not least, the neurodiversity movement, I think, has been a huge advantage for us. And I say this on a personal basis, coming from a neurodiverse family with 2 members with ADHD and another 2 who are autistic. So I think that the concept of dealing with neurodiversity as part of the normal variation is very helpful. However, we do know that for ADHD, that the features of ADHD that we're all familiar with, which occur throughout the population, can become very problematical. And this is particularly if they're pervasive and they're persistent and they cause problems for the people. And in that regard, the features of ADHD become what you might call symptoms and do warrant consideration for whether they need a response, a clinical response. And the dilemma of this, of course, is that 75% of people who have ADHD, where we're not talking about features, but symptoms and functional impairments, 75% of those who are on medication do respond to medication, which helps, which doesn't cure ADHD because it's part of our dementia, part of a person's makeup. But what it does do is, where symptoms are troublesome, it dampens them down to a situation where people can make use of the other supports, environmental, and putting in place strategies to help them manage their symptoms and to allow the other advantages of ADHD to be apparent and for them to become successful. So I think I have another slide, please. So what I'd say is, just going back briefly to the service model, because of the number of referrals we're getting, which reflects very much what is happening elsewhere, I'm now looking at whether we need to look at more of a stepped care approach. And so I'm examining public and private models, disciplines involved in assessing whether more could be done at primary care level. And I would say in Ireland, nothing is being done at primary care level for adults with ADHD. and also looking at the potential for online offerings for people with ADHD. And the last slide that I have here is just to give you the link to the National Clinical Programme if you'd like to have a look at it, and also the link to look at the Adult ADHD app if you have any interest in that. So thank you very much.
Sorry about that, technical issues. Thank you so much, Margo. That was incredibly, I mean, the chat hasn't stopped. Connor has been really on top of things with keeping us informed of every PDF available. So there are tons of questions. I need to put my glasses on to read. Right. First question, is Ireland adding ADHD to the autism spectrum?
Well, what we know about ADHD and AS and autism spectrum as well in Ireland is that currently they're dealt with separately. There is a clinical lead, I think the clinical lead has been changed at the moment, who's looking at developing a service improvement project for people who are autistic, both children and adults. What I would say, I'm extremely interested in what's happening because a lot of people who have ADHD are autistic as well, and vice versa. So it's important to be aware of that, to recognize it, because sometimes you have to modify what is offered to people. And obviously, depending on their own needs, they have their own ideas of what's needed. From what I'm looking at, in terms of adults in Ireland, there are no specific services to provide assessment for adults in Ireland established at the moment, and that is a huge deficit. So I'm following up on that and due to meet someone actually in this coming week because I've seen the model of care and I'd like to see what's going in. And one of the things that I would dearly love to see, and this might be sort of dream, my own personal dream as opposed to any other person's vision, is that we would have something like a neurodiversity hub at primary care level. So if people with whatever neurodiversity issues they might have, ADHD, autistic, dyspraxic, etc., that they would be able to access help and support at primary care level through such a hub. That is my own idea. It's not anyone else's idea, but I think it would make it easier to people if they were just going to one area as an initial step. But we're very far away from that now.
Never mind, we can all dream. Let's dream on, dream on.
Yes, indeed.
Okay. Yeah. So I work with students who have been misdiagnosed with depression, bipolar, BPD, etc. By the mental health services and prevented from accessing adult ADHD assessment. They later went on to access this elsewhere. How can people navigate a situation where the primary mental health services are not knowledgeable enough, re-ADHD, to put a person on the appropriate pathway?
Well, that is precisely why we have a national clinical programme, is to try and provide for people. Because we're very aware, I know myself from my own personal experience, I trained here and also in the UK as an adult psychiatrist, and we received absolutely no training as adult psychiatrists in the assessment and treatment of people with ADHD. And that's the situation in Ireland, throughout Ireland. So one of the benefits of some of the work that we're doing, and particularly Ken's own area of ADHD Ireland, is highlighting the issue of ADHD, specifically in adults, because the child services do respond. And in terms of students, then, we took it a step further to do this review of what medical and support services were available within the 23 third level colleges in Ireland. And unfortunately, on the medical side, there's not an awful lot available. The service that is, I think the person who asked the question was Connor, so I'm presuming he's Irish, but I think the service that is best set up is UCC, University College Cork, where they actually do have a psychiatrist and a couple of mental health nurses and also OT working to assess and treat students with ADHD. And I think ideally that would be the best approach, so that you can, and then part of that approach would be to provide through the disability support services within each of the colleges the sort of supports they'd need, because obviously there's things like accommodations for exams, so more time, you know, doing your exam in on site as opposed to traveling elsewhere for your exam. To have smaller numbers in the room rather than, so, you know, people are distracted by all that's going around them. But also, I think if there were other interventions provided through OT that were specifically directed towards giving people information about study skills, how to approach going to lectures, how to do your notes, how to do a project, you know, the breaking down, there's a huge amount that could be done in the universities. And I think in Ireland, a particular challenge for us is that there are a lot more people with students coming in who have ADHD, because we have two routes in now, and that is the DARE route that makes accommodation. So, you know, it means that there's accommodation given to allow people to actually gain a place in third level university. But also there's an access route as well. So people at the age of 23 onwards can also do a one-year course to get in. So where more and more people are coming in, and I do think if that's happening, then it's important to also provide the supports for them so they don't just come in and then flounder because there's no supports available for them or very few.
Yeah, I just have a quick question. What is OT?
Oh, sorry, occupational therapy.
Okay, sorry.
Sorry.
No worries.
Mm.
Okay, I'll just read this question. Asking not to refer for ADHD until the SMI is treatment. Sorry, is treated. Strikes me similar to the old. We can accept for mental health until the addiction is treated. Dot quote. Shouldn't both be addressed together, especially as mental health and ADHD drugs can interact and indeed expertise to manage together and need expertise to manage together.
Is that substance misuse or is it not?
I don't.
SMI, is it severe mental illness?
I would guess so. I have no idea. Not familiar with any of these.
We would expect that the two services, if you're talking about people who say have a bipolar mental health, bipolar diagnosis, or maybe severe recurrent depression, the expectation is that the two services would work together hand in hand. In some cases, the symptoms of anxiety and depression are actually more a secondary effect of the ADHD, and where that's the case, that needs to be recognized and treated. But in other cases, the person may, for instance, have a severe depressive episode, and if that's the case, that needs to be treated first of all, because otherwise they're not really able to take on board all the work that's required to, because it's not a passive process. If you've got ADHD, it's important to try and engage with the help that's offered to you, and if you're severely depressed, you're not really able to do that. But I would say the services are within the same catchment area, so they do work hand in hand. The teams know each other, and you know there should be a lot of back chat, back and forth about people.
So, if the teams are not close together, then they still need to work hand in hand. That would be useful.
Yeah. If it's the public service, and our model of care, they would be close together.
Yes.
So everyone would know each other and be able to discuss someone, you know, maybe if there's a query about how to proceed with their care.
Yeah, very interesting. Okay, there's this person currently going through RF through referral. Okay, I think you've written it again. Currently going through referral through HSE in Limerick. GPs ask very limited questions to go for referral. Example, do I forget appointments? No, because I write in 2 places, but on the phone, etc. Is there any plan to increase GP training to help referral processes?
Yeah, there has already been done some GP training, and there's I'm aware of it because this is a newish area as well to GPs as well as those of us in the mental health service. So, for instance, very recently, actually in Limerick, there are 2 GPs based in Dublin who have developed the expertise of being ADHD specialists themselves. They work with, they've set up a private service and they're working with consultants as well. So between them, they've got a very nice and efficient service running. But one of those GPs actually delivered a talk to GPs in University of Limerick, I think about a month or 6 weeks or so, and it was, I gather, very well received. And then we have working with us within the mental health programme a GP, and she's liaising with the Irish College of General Practitioners as well. So it's like anything new, it's going to take a bit of time before that becomes, before all the GPs become totally familiar with ADHD in Ireland, or in adults, sorry.
Yes. Okay. No. Asking not to refer. I think sorry, should have done that to this one. Can you tell us more about ADHD in women in Ireland? What does that involve?
Well, what has been recognised internationally now, a lot of women get a late diagnosis, and that's because quite a good proportion of girls don't present with the typical symptoms of hyperactivity and impulsivity. It's hard to miss the boys because they're so jumping all over the place. But some of the girls, quite a few of the girls are missed because they're just sitting quietly at the back of the class, they're looking out the windows, they're daydreaming. And it's really only in adulthood that it becomes apparent that they may have problems. And I think there's sort of key points. One of them is if the girls are often very well supported at home. So if they go away to university, for instance, and they're away from home, suddenly that's a huge challenge because not only do they have to organise to get to the right place for lectures and organise to self-direct the way they learn, which is quite unlike what secondary school is like, but they also have to look after themselves, feeding, washing, etc. And trying to juggle all that, if you've had a good supportive network at home, can be quite a challenge. And that's when they may run into problems. The other times might be the times of hormonal challenge. So sometimes puberty, it can emerge. Sometimes people will notice that there are changes with menstruation and wonder why that's happening. During pregnancy, that can be an at-risk time. And then when you have the baby, then you're suddenly not just responsible for yourself, but responsible for a baby, and trying to manage that and sort out that when we know that people who have symptoms as opposed to features of ADHD can have huge problems with organizing things. So organising the baby and responding to the baby and all the extra work that's required, as well as looking after yourself, that can be a very stressful time as well. So where the study we've got, we're just starting really to look at that. We're developing the questionnaire, and one of the doctoral students who's working with Jessica is working on that at the moment. There's been a very good Dutch study done that looks at that as well. So it's more or less a replication, because in terms of advocating for services in Ireland, if you can show that these things are also happening here, it's a strong message to be able to give.
Just while we're on the subject of women, has menopause come up in your research?
Yes,
study?
It has, and that's one of the areas we're going to be looking at as well. Yeah.
Okay. Sorry. Okay. Sorry, I now have to find the other questions. Okay, thanks, Margo, for a very helpful presentation. This person has 2 questions. One, when is it likely that the areas have not yet been covered by the MOC are likely to have an ADHD service? And 2, are there any plans for accessible clinical pathway for autistic people with psychiatric disorder?
In terms of the first question, we can set up new services where we're given funding. And unfortunately, this year, 2023, we had applied for funding for the rest of the services, really, and there was no funding allocated for our clinical program. So sadly, we won't be able to set up any new services, but we will be advocating for more funding next year, and hopefully we will get some, because obviously we're limited in what we can do. If we don't get the funding, we can't get the staff, we can't train the staff, we can't put the services in place. So
okay.
Oh, and the second question was about autistic people specifically, was it, who have comorbid mental health problems?
Yes, I'm sorry, it's gone. I've just get it from the other. No, here, just go and fetch it. Are there any plans for accessible clinical pathway for autistic people with psychiatric disorders?
Yeah, so I mentioned earlier on that there is a HSE service improvement project, and I have seen the draft proposal in that, and it contains a proposal for how people autistic people with moderate to severe mental health problems should have access. But it is very much at the draft stage of a proposal, so it's going to take a while before anything comes out of that. But at least it's being considered now, which is light years ahead of what was happening a short while ago.
You seem to have moved at warp speed, if I may say, but you know. Yeah. Okay. Were other disciplines considered to be members of the adult ADHD teams, e.g., social workers, speech and language therapists, and have they a huge role? They have a huge role in children and teenagers with ADHD.
Yes, that's true. And the children and teenagers are treated for ADHD through the child and adolescent mental health services. And both of those have social workers and speech and language therapists involved with them as well. Now, in terms of the adult services, if people do need access to social work services, they could access social work through the secondary care adult mental health team, so it is available. I would hope that if my dream of a neurodiversity hub structure comes to pass, we will have speech and language therapists involved in that as well, because obviously that can be one of the neurodiverse conditions that can occur and requires, and in some cases will require support from SLT.
So what do you think are the major barriers for adults with ADHD seeking help in Ireland?
Well, I think I used to think it was because people didn't know about it, but I think it's really swung the other way. And in some cases, I think it's swung a bit too far, because there is this sort of TikTok phenomenon of people thinking, oh, well, you know, maybe that explains everything. And so we're very keen that people, before they're referred, would actually access information about ADHD. That's very freely available through ADHD Ireland, and there's also the app on for adults with ADHD. So we're very keen people would access reliable information, because if we get people who just sort of decide, well, maybe that's it, and they get themselves referred, it just means that it increases the referral load and means that everyone gets seen slower. So yeah, so that's one, but what I would say is the main access really is getting funding to set up the services. And then even when we get the funding, it can be a challenge to recruit all the staff, particularly the staff member that's hardest to recruit is actually the psychiatrist. So one of the services that we did get funded last year, we've recruited all the staff, but we haven't been able to recruit the psychiatrist yet. So we're going to try again using an international recruitment agency to do that.
Okay, Margo. Well, unfortunately, one last question. We've got to answer very quickly because there's so many questions. Do you have a view on using screening tools for ADHD? Is this a good idea for state services to consider, or is it more appropriate using clinical diagnosis?
Well, we do use screening tools when people have first come to the service. They come to the adult mental health service. So we use the the ADHD rating scale, and also the WERS with the Wendell-Utah rating scale to identify people, whether there were symptoms present in childhood. I think what's coming out now is that people are very familiar with these scales and are having a look at them beforehand and know how to answer them. So you can never, ever escape the importance, the central importance of a good clinical interview for a person, including their history, their mental state, the collateral history, and then using the DIVA as well. And I think for any of you who saw the Panorama programme, that certainly brought that forward, how important it was. To be assessed for ADHD is not a short process. It takes about 3 hours to do a thorough assessment, and usually it's divided between 2 parts, the initial assessment and then a diagnostic interview. So no, one doesn't replace the other.
Well, thank you very much, Margo. It's been really insightful, and Ireland seems to be zooming along. So we hope you dream on and that we create this wonderful world that you obviously see.